Good evening, everyone. iTech India welcomes all the participants for today's Module 9 session. Today's topic is using data for management decision making, and the speaker is Dr. Nilesh Gawde. Sorry for that error. Dr. Nilesh Gawde, sir, has completed his MBBS and MD in Preventive and Social Medicine, that is PSM, from Mumbai University. Currently, he is the Assistant Professor at the Center for Public Health, School of Health System Studies, TISS, Mumbai. He has been working in the field of tuberculosis and HIV/AIDS in various capacities over the past decade, predominantly as project director for capacity building, researcher, master trainer, consultant, etc. His areas of expertise and interest include migration and access to health, program evaluations, non-communicable diseases, etc. We welcome you, sir, for today's session and request you to start the session.
Thank you. So, good afternoon. I'll be talking on using data for management decision making. And thanks for this opportunity to iTech for giving me this opportunity to interact with you. Uh, what I understand from iTech is that many of you are mid-career professionals who have the experience of working in projects, and you are pursuing this course in leadership and management in health. The original design was from University of Washington, and I am facilitating the content of this particular training session. So I'll talk about for about 45 minutes to 50 minutes, and we will cover this session there. But please also note that there are video links, and you are free to go through that also. In either if you have already gone through, wonderful. Otherwise, you can go through that later. The presentation is almost on the same lines. However, I will try and use some of the Indian scenarios or examples during this course. So is the slide moving?
No, sir. Click anywhere on the slide and then next button, please.
Uh, just a minute. I think there is a pause share.
Can you try sharing screen again, sir?
Yeah.
Just click on enable editing, sir.
Is
Go
it
back.
better now?
Yeah, it's better now. Yeah, the slides are
Now
moving,
have
sir.
we reached the learning objective
Yes,
slide?
sir. Yes, sir.
So the learning objective is to distinguish between monitoring and evaluation. So we will do that in one of the subsequent slides. Identify what are the different sources of information for MNE. Understand the relationship between the two: effective management and leadership. Sorry, it has gone 2 slides ahead. Sorry. And leadership skills. Determine the purposes of data for accountability and public health effectiveness. Identify the role of leaders and managers in creating an organizational culture of information generation and use, and integrate insights from self-assessment, learning, reflection into individual learning plan. So these are our learning objectives. Resource materials are already available to you. So we will talk about monitoring and evaluation, what are the data sets, and the two dominant method of quantitative and qualitative. So when it comes to data for decision making, why do we need this data? Because it helps us to strengthen the programs and improve results. So when we talk about monitoring, we actually are collecting data within our intervention. This data is typically input, process, output, and often this data itself will help us improve our program, improve the result. Many times uh, we are focused only on the outputs or outcomes, like what is the coverage of X particular intervention, how many people utilize the service. So that is our usual focus in monitoring indicators. But often, if we are not able to achieve our coverage or not able to have utilization as per target, the reasons are somewhere in the inputs and processes. Maybe we do not have enough resources, or there are some bottlenecks in the processes. Maybe the training hasn't happened, which is a process, or procurement hasn't happened, which is a process. And that is why we are not able to uh, yeah, just are you not able to hear well? Is still there some disturbance?
So there's some background noise from students, I suppose.
I'll just
Yeah,
give
yeah,
us
yeah.
one
Sure,
minute and I'll
sure,
come back.
sure. Requesting participants to kindly bear with us.
Yes, I hope it is better now.
Yes, sir. Thank you, sir.
So so if we can use the input data and process data, then we will realize that, oh, this particular input is missing, or this process is getting delayed. Often what happens is the input and processes happen very early in an intervention or early in the program, whereas outputs may take time. It may take 6 months, it may take 12 months. So if we focus only on the output, then we kind of and if we miss out on the input and the process indicators, which are very important for monitoring, then we are in a situation where after 6 months or 1 year we will realize that, oh, we are not achieving the outputs, and that is because the inputs and the output and the processes were not in place. So with monitoring, what happens is we are able to also tap on input indicators, process indicators, and they help us strengthen the programs, improve the results. Monitoring and evaluation both helps inform policies. We can get additional funding. Also, often there is a concern about accountability. If a project is doing good, wonderful. But if the project has certain challenges, then sometimes it is expected, especially if it is a funding agency who is giving funds, they would like accountability within the system, with people, with the recipient organization, and that also can be ensured through M&E reporting formats. Because we are reporting as an organization or as a project on a regular basis, the achievements are reflected, so accountability can also be determined. It helps us in better results, and when we improve, it also improves staff motivation, and overall M&E systems improve transparency. Then we don't say too few, too many, very high. We actually give numbers, we give percentages, we give percentage performance in terms of how well we are we with respect to targets. So data is very essential for decision making. There is also a video link, and I would encourage all of you to have a look at that. So there are types of data that we collect. Now, in research, we do collect quantitative data and we do collect qualitative data. At times, people believe that when we are running projects, we collect only quantitative data. But that's not actually true. We are also collecting a lot of qualitative information. It's only that in most of the funded projects, we are looking at targets and achievements and whether it is achieved or not achieved, and or what is the percentage of achievement. So many times our questions are how many, to what extent, and we give quantitative numbers. But we also have often qualitative information, which is why this is happening, how this is happening. If we have only quantitative information, it tells us about where we are with respect to our target or objectives. But if we also know why we are there, or how we have faced challenges or not faced certain difficulties, then we will be able to take action. For example, let us say you are implementing a particular project in a state, like say Maharashtra, which may have 35 districts, and you may get indicator for all the districts of how A district is doing, B district is doing, C district is doing. Quantitative will tell you which is the best performing district and which is the worst performing districts. Sometimes the quantitative indicators, there are multiple indicators, so sometimes they will also tell you of why it is happening. but maybe you also would need some qualitative information to understand why this indicator is showing like this. So that's why qualitative information is also very important for monitoring purposes. Uh, Both the qualitative data and quantitative data can get these things done. Since you are already working professionals, instead of giving you examples, I would present you data and you tell me whether this is qualitative, quantitative, and how it can be used for M&E. So which of the two you think? Suppose I say that there is a particular data which captures depth of the situation. Which data or type of data I am describing, qualitative or quantitative? You can unmute and respond, or you can put it, I think that will be, or you can put it in chat also. So Dr. Vijay has mentioned qualitative, Amrita has mentioned qualitative. Yes. Someone has mentioned also quantitative. Quantitative usually does not capture depth of the situation unless you have multiple data points and multiple indicators. It becomes a little difficult. So qualitative is the right. I mean, I would rather put a disclaimer here that when we are capturing depth of situation, it can be done both qualitatively and quantitatively. It's not that quantitative cannot go to the depth, but qualitative does it far better. It can find out why this has happened, how this has happened. Now, if we talk in M&E terms, which of the two is more objective, qualitative or quantitative? What do you think? We are moving to second question now. You can put it in chat. More objective, qualitative, 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 and qualitative. Okay, so there are four responses which say that qualitative is more objective, but actually it is not. So quantitative is more objective. For example, if I take, I'll take examples from different projects to explain my point. Let's say that there is a intervention for HIV prevention with high risk group, and we which information will be more objective? I will say that the number of high risk group persons belonging to high risk groups are registered with the organization, or the number of persons who are high risk groups who are visiting a particular clinic or availing a particular service or have discontinued a particular service or are last to follow up. So when I am counting the numbers, that makes it more objective, because whether I collect it or one of the participant, whether Dr. Vijay collects it or Amrita collects it or Leena collects it or Seema collects it, the number will be same. So quantitative is more objective because we can look at the records, we can calculate the numbers based on whatever is recorded already, maybe, but all of us can get a definite number. But if I put qualitative information where we ask people, what did you feel about the service? That is more qualitative. We are asking opinion of people or what did they felt about it. Then that is qualitative information, which is very subjective information. So more objective is quantitative data. Numbers are more objective. Irrespective of whosoever is collecting data, the numbers will remain the same. But if we are asking different people to give their opinion or expression, then it becomes a little subjective and the answers could be different. I hope I have clarified that quantitative is more objective. Any queries on this? Yes. So one of the person is saying, participant is saying, it depends on the study objective and the kind of study design. Yes, it does depend on the study objective and study design, but qualitative data is not expected to be objective. It is expected to be subjective because people are giving subjective impressions about the particular phenomenon. So between qualitative and quantitative, quantitative is more objective. We can choose quantitative method or qualitative method depending upon study objectives. Sometimes the study objectives will warrant quantitative design. Sometimes the study objectives will warrant qualitative design. And sometimes the objectives will warrant a mixed method design also. But between the two methods or between two types of data, quantitative data is much more objective. It is which data, qualitative or quantitative, is easy to compare results. Quant is easier to compare or qual is easier to compare. The first participant is saying quantitative. Others may also say quant, both, but yes. So all of you are who have put your comments in the chat, all of you are agreeing that yes, quantitative, it is easy because I can compare X district with Y district. What is the percentage of patients who have received institutional delivery, or say percentage of pregnant women who had institutional delivery in A district and B district. So quantitative is easy to compare because we get numbers, we get percentages, we get indicators, we get proportions. So quantitative is one which we find it easy to compare results. Which of the two takes longer time to analyze? Qualitative takes longer time to analyze is what first participant is saying. Anyone else wants to add? Qual, yes, because qualitative information, whether in research or in real surveys or in research or in real M&E situations, the data analysis may take time. Now between the two, qual takes more time. However, one of the participant has said it depends on data, and that also I agree. Suppose you are having quantitative major survey, which is long schedules, and you are collecting data from thousands and lakhs of people, then even quantitative data will take longer time to analyze. But in quantitative data, when we are using survey, often the structure of the uh, questionnaire or interview schedule is pre-decided. So what kind of tables are to be generated is also pre-decided. So we actually, before even starting data collection, the dummy tables can be ready. And in that case, and we can also keep the syntax ready or commands ready for a particular software application. So unless there is too much of data cleaning which is necessary, quantitative data gets easier to analyze because a lot of things we can pre-decide and prepare. But qualitative takes much more time to analyze, often because of the kind of country in which we are living, because this most of the participants here are in India, and when we do qualitative studies or qualitative components in M&E, giving different states have different languages, the qualitative data is usually collected in the form of field notes, in the form of interviews, in the form of focus group discussion. So a lot of this is data in different languages, and it is audio data. So a lot of time is then spent in transcribing the data, in translation of the data. And then once the data is there, it is textual form. Most data is textual forms. Now, newer methods of qualitative data are also collecting data in a pictorial format or in a video format and so on and so forth. But this data is very rich, very heavy, and person has to read through and read every line of the transcript, then code. Sometimes you can prepare the code book in advance, but often we rejig the code, we redesign the code based on the data itself. So it takes much more time for qualitative data to get analyzed broadly. But yes, sometimes even quant data will take considerable time for analysis, but qual is takes much more time. Now, last is which of the two is generalizable, where you can generalize, quant or qual. Which data is more generalizable? So I think one person has entered quant. Anyone else wants to add whether quantitative data is generalizable or qualitative is generalizable? Quantitative, somebody saying qualitative? Yeah. So I'll explain. Um, Qualitative data is not meant to be generalizable, usually. It is about opinions of people, perceptions of people, their life journey, their experiences. So it is usually not meant to represent the whole population. You can't generalize usually qualitative data and apply to the masses. Quantitative data, however, has potential of generalizability. That doesn't mean that quantitative data can always be generalized. If the sample is taken in a probability manner and the sample size is adequate, then you can, you know, generalize it. For example, let's say I want to study something on tobacco smoking in let's say in the whole of the country, and I choose only college premises at 4 metropolitan cities, and I do a sample of 100. It's a quantitative survey I have done, but does it represent or can I generalize it to the whole country? No, maybe because the geography is not covered, maybe all age groups are not covered, maybe the way I'm going and interviewing only college going persons, so only a particular section of society will get covered. So I cannot, even in quantitative there are concerns on generalizability, but they can be addressed at the design stage itself. You can devise a household kind of survey, or you can take a representative multi-stage stratified random sampling with some weightage given to or consideration given to the social fabric like caste, tribe, female, male, literacy status, and so on and so forth. So you can do stratification implicit, explicit, and one can have a design which so that you can generalize your findings. So that possibility is there in quantitative. Qualitative by its very nature does not have that potential. So we move to the next one. The next two slides are actually um, the the summary, and it is as in the provided in your um, study material. So I would request you to go through this. The advantages that we did not discuss of quantitative is that it is said to be more standardized. You can make the questions very standardized and ask not only in research study, but also when we are running projects and we are having regular data flowing on a daily basis or on a monthly basis, we can standardize our data collection formats. We can standardize definition of of the disease or of the person or of the behavior, and quantitative helps us in that. For example, let's say you are conducting a intervention for non-communicable diseases and you are capturing data on physical activity. You can really make it standardized by say, is the person, how many number of times or number of days the person is having physical activity, then on a given day how many minutes or how many steps count, or so something like that will make it more standardized. In a quantitative data one can one that has advantage that you can make the tool very standardized. um, it is also less risk of person bias. We have discussed the rest of the points of quantitative. This is on qualitative. This also we have discussed largely, that it helps us to better understand the context, but the disadvantages it longer to analyze and not very generalizable. Now, when it comes to data quality, there are various things that we are aware of. And because you're working professionals, you would have heard this term validity, reliability, completeness, timeliness, precision. The study material provides you with the definitions and examples. For discussion, I have brought here 5 situations and I would put it to you. Let's say you are M&E official working at your organization and you observe that you have reports coming to you from your feeding units, from your uh, project districts or NGOs or whichever are the reporting units. And you observe that reports are received with some delay, and real-time data that you had created some web portal, and in 2 centers it is lagging. What kind of data quality issue this is? And I have listed there those 7 8 points. So somebody saying timeliness, yes, absolutely. So it is very straightforward. It is timeliness that we are looking at. That is very important part of data quality. If timeliness is if the data entry or data submission is not timely, then we will typically underreport cases, yeah, or underreport our performance. Next, one clinic, half the patient forms have missing data. What kind of issue it is of data quality? Completeness, someone is saying. Yes, it is completeness issue. And this is a major problem. What I have noticed that in country like India, where we have developed good IT infrastructure and we have developed formats which where there is a submit button. Nowadays, we are having this issue of completeness and timeliness actually are having an interplay with each other. How? Earlier, we were not getting reports in time, and the reports that were coming to us were also incomplete. Nowadays, because of the submission timeline, that before this date only you can submit, and after that, the web portal itself will not be functional. So, people are forced to report timely. So sometimes completeness may get jeopardized. But also other thing which is happening now is that when we are designing forms, many forms, many times unless you enter something in each and every field, you can't place the submit button. So the moment the report gets submitted, it is usually the report, I'm saying report completeness is usually there, but it may be at the cost of accuracy. So because of the IT systems, timeliness and completeness of the reporting has improved. But does that mean in the raw data, there are no missing data? There may be missing data. So when we are collecting information, there may be missing data. It's only the IT technology has improved completeness and timeliness in reporting level. We move to the third one, which is status of HIV positive. And this is one example. Status of HIV positive is written boldly on all indoor and outdoor patients thing. What kind of quality issue is this? Yes, it is a confidentiality issue. And we, in whichever system we are, we need to be aware about the stigma, discrimination that patients or individuals may face. And we need to have systems so that we want the data to flow, we want the data to get recorded, but we want to have systems where data is kept confidential because it can have implications for patients. We move to the fourth. Patient is referred from pre-facility to Q facility. Referral is said to be complete when patient is given the form. What kind of issue may arise in terms of data quality? Patient is referred from one facility to other facility, and it is said to be complete when patient is given the form. Integrity, okay. Anyone else? Validity, okay. Anyone else? Precision, okay. So there are variety of responses, okay. So I'll tell what this could be. So it can be multiple. So I agree with the person who has said integrity, because this integrity is not about data per se, but it is integrity of the M&E system. if you are ideally how it should be done in this case, if patient is referred from P to Q and the referral is said to be completed when patient is given the form, that's not actually true unless the facility Q reports to P that this particular patient has reached. Then only we can say that the referral is complete. So there are both issues of integrity and validity. Integrity is because we have developed a system where when a referral form is given, P facility can enter into their database patient referred and reached probably. But that's not true. So in M&E systems, we need to keep the integrity strong and should have a provision only when the Q facility reports back the number of the patient, then P facility can say yes, referral completed. So that's the M&E officials have to create that integrity in the system. But also from logic point of view, it is a validity issue because here we want to, what do we want to measure? We want to measure whether the patient completed referral or not when the patient is given the referral slip. Whether patient completed a referral or not, that is what we want to measure. And if that is what we want to measure, we have to note whether the referral is completed by where the Q facility should report back to us. So it is both validity and integrity issue. Integrity from an M&E system point of view and validity from the example point of view, where we are not measuring what we are supposed to measure. We are measuring referral slip given when we are supposed to measure referral complete or not. Okay. Now the last, a BP instrument gives fluctuations in reading. What kind of data quality issue can crop up? Precision and reliability. Okay, that's what one is saying. Reliability. Yes. So there are 2-3 answers. Somebody is saying reliability and somebody is saying precision. Yes, it's a reliability issue because when a person is doing these measurements again and again, if there is a different reading, then it will not be reliable. So it fits into reliability. Precision also can get affected, especially if in a case like BP, where for research studies we don't take just one reading, we take 3 readings. And if the 3 readings are different from each other, far different from each other, then precision will get affected. So both precision and reliability data quality issues can happen. So you have a lot of actually reading material which talks about what are these different data quality concerns. And these are the definitions. They are already available to you. And I would rather like some more discussion for the remaining slides. So I'll go ahead. I'll just give you half a minute. In case anyone has query on any of these, you can pose in the chat. I give you half a minute to read through this particular slide. We have already taken examples. Thank you. I do not see anybody in the any message in the chat. So I'll proceed. I assume that you have broadly understood the data quality concepts. So I'll move ahead. So when it comes to data and evidence, there is a video link. I would encourage you to go through the video link. And it is important that we start using data. Often what happens is, and this whole slide is, and also the next issues are about, unless the people who are collecting data, who are transmitting data, and who are expected to report, unless everyone starts using the data quality also doesn't improve, and data is not used for evidence. So it's important that we start using data as evidence and take actions according to it. Even if there is no evidence of a particular thing, one has to then look for evidence. You look for what are the challenges, what are the problems, and based on whatever data that is available, we need to take decisions. Often what happens is people don't link data and decision making together, because for people who are actually collecting data in a monitoring system, when you are running intervention and people are actually in health, usually it is the doctor is taking data or nurse is taking data or lab technician or counselor, somebody is collecting data while they are also providing service. So they are noting that data, and much of these registers and data, they are also transmitted up in the hierarchy, and lot of details are there, and they feel that our role for data is only collect data and transmit data. So they don't necessarily start using that data. If they can start using that data, it will be very useful for the patients or clients whom they are seeing. Also what happens is, in current M&E systems, we are actually in there is one problem with M&E systems, that M&E managers at the very top level feel that we need every data. So they ask the ground level to collect all types of data and transmit everything to the up. One thing which M&E official have to note is that the requirement of data is different at different levels. So at the most peripheral level, or when there is an interaction between the provider and the client or patient, there they need data which can meet the patient client management. So that data has to be there. Some of that data need not travel up, because up you need strategic information. You need only a few indicators. We see across many programs that more than 100 data elements, 500 data elements are reported on a monthly basis to the top management. But when it comes to decision making, what indicators the top, and just look at what decisions top management is taking. Often it is on the basis of handful of indicators. So in such a case, we need to put a hierarchy of indicators of which data will remain at the local level only, which data will get transmitted up, and whatever data is coming, how to use that. So at different levels of leadership, you need different levels of details, and one also has to then accordingly put the technical issues and political issues that come along. One has to understand what is the role of leaders and managers in information generation and use, and there are a lot of points on this slide. Also, I'll take one or two points for explaining what I want to explain. So, as I was saying in the previous slide, we are collecting a lot of data. Now, the question is, will the findings primarily be for just reporting? Because I have to collect and I have to report, I'm going to report. And I, or do I have actually use of all of those indicators? So, for a particular program, if I'm having 50 indicators, then I have to actually wonder whether I'm going to what decisions I'm taking on a monthly basis. Am I using all these 50 indicators, or is it actually a handful of indicators? So this particular thing is the role of M&E managers. This is not role of the persons who are actually collecting data. So while creating M&E systems, please look at what decisions we are taking on a day-to-day basis, or what decisions we are taking on a monthly or annual basis. For that, what data is required, and let us look at only that much data in routine monitoring systems. Because what happens is, we usually prepare a detailed information, detailed data, and then it is a burden for the data collectors. It's different in research. Research doesn't get affected so much, but in routine monitoring, the same person is collecting data and the same person is also providing service. So too much of data collection compromises on actual service delivery, and then the service delivery doesn't happen, but only documentation happens. So while designing M&E, one has to think about what is our role. and what kind of data we should collect, and how it will contribute into public health practice or patient safety or population safety. So one has to have that role very clearly. Then one also has to have transparency. Who all should have access to data? In our M&E systems, we are actually improving transparency and access. But in many M&E systems, we still are having a question that does the client or patient, whose data is it? Is it accessible to them? We usually had data accessible only to the most peripheral worker in the past, and now we have improved the transparency that we are giving them tablets or some device so that they enter the data on a real time basis, so that many other people can see the data. Their supervisors can see the data, they can supervise easily. There is accountability built in the system, because sometimes it, people, we have faced situations that the workers do not necessarily go to the field, but they say that they have gone, and then real time data actually can make them accountable. But that is only one aspect of the thing. One needs to also look at whether patients are having access to data. So who needs to see the data, who can see the data is important. What are the expectations around data use, where we should focus our evaluation efforts, and all of these are very important transparency questions. If there is something important new that is happening, it should get documented and should get transmitted, reported, recorded, and like that. So these are some transparency points. I'll move to the next one. We need to keep a tab on what resources should be committed for M&E, because for M&E, as I said, the most peripheral person or frontline person is the same who is providing service. So if you do not have adequate resources, it will compromise service delivery. So we need to know who will do data collection, and then after data collection, how many staff we need to clean the data, to process data, to type data. So do we need data entry operators? Do we need M&E officials, assistants who can clean the data, who can prepare these tables? Or even if we talk about IT systems which can generate dashboards, which can create monthly report and give it to you in a user friendly manner, still we need money to engage with that IT company. So one needs to still keep tab on resources, money. One needs to have how the results will be used and shared, who will need data. If we are getting some data from routine monitoring, where to focus our evaluation efforts, and how do we present data? We have a lot of monitoring and evaluation indicators. We have big charts, big tables, but when it comes to a official who is a policy maker or a politician who needs to take certain actions, then we need to also present data in a manner in which they can understand, comprehend, and take actions. There is one interesting link. I'll not detail about this particular case, but this is one case you can refer to it. It's from Tamil Nadu and Bihar, and it talks about how the indicator on water and sanitation was not too different in these two states. If I ask you a question, between two states I'm naming, Gujarat and Bihar, do you think that one state will be very good with respect to infant mortality and other will be very poor with respect to infant mortality? If I may ask, which will be good? I'm just naming two states, Bihar and Gujarat. So actually, no is someone who is saying. Anyone else has idea? So if I, yeah, that is what usually, yeah, some person has said Gujarat we may think as good, Gujarat is best. So yes, the state is usually very good. It has better infant mortality rate than Bihar, but it's not poles opposite. So even a state like Bihar doesn't do exceptionally poor in terms of infant mortality. So why then, if Bihar is doing so much, why Gujarat is doing only little better? Why not more? So that those are the questions which sometimes can lead to different action point. I'm just sharing some of this. This particular case of Tamil Nadu, Bihar is mentioned for water sanitation. It is there in your reading list, and that actually led to certain actions. Now moving to the last part of the presentation is what is monitoring, what is evaluation. Monitoring is tracking whether the project or program is being implemented according to your objectives. So you actually see whether the inputs are coming regularly, whether the processes are happening, whether the outputs is happening. So monitoring is on a day-to-day basis. We are collecting data daily. We are reporting data sometimes daily, sometimes weekly. For example, can you give me one example where data was being monitored on a day-to-day basis? Any of the last 5 years where data was monitored, reporting was happening on a day-to-day basis? COVID, yes, COVID, where the data was getting reported on a regular basis. On a daily basis, we were counting number of patients, number of deaths, number of people who are quarantined and off the quarantine and like that. So their reporting was also on a daily basis. But often our reporting is on a weekly or a monthly basis. In IDSP, the reporting is on weekly basis, but most of the other health interventions we report on a monthly basis. Sometimes we even report on a quarterly basis. There is someone who has mentioned about Soch. Soch is it's a software which is which captures expected to capture real time data. So in this, and not only Soch, but if you look at RCH portal in RMNCH plus A, or Nishchay portal in TB, so so there are so many portals where real-time data entry happens. That doesn't mean real-time report generation or analysis also happens. It's real-time data, but not reporting or calculation of indicators. However, it can give dashboards. So on the basis of currently where we are today, it can give dashboards. But so with recent real-time data that has helped, but usually monitoring is on a monthly basis, because we don't, although the data is flowing real time, decision making doesn't happen every second. For decision making, we sit on a monthly basis and say, okay, what is the performance in the last month, and let's look at whether project is being implemented as planned, should I change the course, and so on and so forth. So there are uses of monitoring, and all those you can go through. That is what is helps when there is monitoring. Whereas evaluation is not routine, it is usually periodic, and we look at whether the set objectives are being met, whether the intervention is able to, whether the project program intervention is able to make change in the situation. So even in evaluations, there are different types of evaluations. There are formative evaluations, process evaluations, but most often what we are familiar with is the output evaluation or impact evaluation. Output evaluations actually measures only whether the outputs are achieved as they were planned, but most valuable interventions is impact evaluations, where we measure whether there is a change. For example, there is a, let's say, tuberculosis. We are now in tuberculosis starting TB prevention therapy. So the household contacts of TB patients will be given some medicines. Maybe after 3 years or 5 years, we could do a impact evaluation and find out how many of the contacts of TB patients have got the disease without TPT, the TB prevention therapy, and with TPT. And that would help us understand whether the thing is really effective or not. yes, develop TB disease. I'm sorry if I pronounce something incorrect, whether they develop TB disease or not. So evaluations, impact evaluations can be something like that. Or RMNCH plus A interventions, how much change they brought to maternal mortality or infant mortality. So those are impact indicators, whether what change there has happened, and that can be usually done through evaluations. Evaluations are also important, some of to understand processes. So there have been a lot of process evaluations that NHM conducts on a annual basis. And this evaluation data helps leaders align, mobilize, inspire, and a lot of findings so that one can revise strategies. Evaluations happen usually periodically, usually 2 years, 3 years time period is there before we undertake evaluations, and so that one can either consolidate or change the intervention, and accordingly one can proceed. There is also an example on accountability and decision making. So I'll just read this particular point. We are towards a close. Some people are argue that money spent on M&E is money not spent on implementation, but without adequate resources spent on monitoring and evaluation, we will not know whether the program is being implemented, whether it's giving results or not. So we won't know whether the money spent for program is worthwhile. So identifying balance between resources spent on intervention and on monitoring is what is very important leadership decision. And that's where accountability and decision, because what accountability in terms of whatever money we are investing, if it is not giving results, then why we should put money into that project? We should put the money into some other project. So accountability for that intervention is so important, and M&E only can give us that answer. And leadership has to always look into how were data presented, what change has been caused because of the intervention, and how we can use the data in future. There is one comment: a pilot study can be considered as evaluation. Pilot study is not considered as evaluation, but it is field testing. So when a particular intervention is implemented as pilot, one can do evaluation of the pilot so that you can strengthen the intervention. However, most times when a pilot study is done, it is not meant for impact evaluation, because impact takes a lot of time. Usually pilot studies are done to find out whether people will accept it or not, whether the intervention will run smoothly or not, what will be better. So there are some pilot studies which have one kind of evaluation which is called as formative evaluation. Formative evaluation is usually can be combined with pilot study, in which we look at the design of the project and we try and implement it at a pilot level and see whether it works or it doesn't work. And if it is not working, then we make changes to the design and then implement it. So at the most, I can say pilot study can fit into formative evaluations. Okay. Need assessment is something entirely different. Need assessment is not necessarily evaluation. It's an entirely different thing altogether. Okay. So I'll move to the next one. So this is an exercise which was stated, and this maybe will be given as a exercise for you by the program organizers. What are three important sources of data for effective decision making in your current job, and why? And is there one way in which you could encourage or contribute a stronger culture of data use? How you can do that in your own organization? And how does data for decision making relate to the concepts of accountability? So you could do this as a home assignment, and how that will happen will be conveyed to you by your uh, program organizers. So I stop the thank you, and if there are any questions at this juncture, I can take. There are 5-10 minutes, I think. Yeah.
Thank you so much, sir, for the wonderful session. Any questions from the participants? Mic access has been given to all. Pilot studies.
So the question that one of the participant is asking, if pilot study is similar to need assessment. Pilot study is not necessarily similar to need assessment. Even when we use the word pilot study, the term pilot may be used in two different settings. For example, when an individual and organization is doing research, a major research study. Before a major research study, they may do pilot for before any major research, so that the questionnaire or interview schedule can be assessed. Like for example, I was part of global adult tobacco survey which our institute did, and we conducted a pilot study before the actual survey so that we could look at each of the question that we had put, whether people are able to understand the question, whether we are able to get the data, should we change the order, should we change the skip logic, and so on and so forth. So pilot for research means something different which can be done. What I was referring to during this presentation for pilot is pilot intervention. For example, let's say I was talking about say TB prevention therapy. Now, this TB prevention therapy is a known, and it might have been studied in randomized controlled trial or something. But when we come to a particular field level, in field we have things ready with us, and we an intervention is planned, and we try and implement it and see whether it works well or not. We may have a lot of points that may come up in the pilot implementation, and on that basis we can refine a lot of implementation things. We may have certain things which will not work in real life. We may have data collection forms which may not work in this. So pilot helps us what will work, what will not work. If we don't do pilot and we start implementing across, and then everywhere it's a issue, so it becomes a challenge. So that is about pilot. Need assessment is entirely different. Need assessment can be a simple study. It may be training need assessment, it may be doing a survey in the community. It need not always mean intervention. Pilot in intervention means that we implement, we run something, and we see how the pilot is being accepted or not by people. Whereas need assessment is just a understanding where we want to, where we can do it through quant or qual means, but we are not necessarily running the intervention.
Any more questions?
Okay, is that clear? Need assessment can be done in any of the setting. It can be done in refuge, it can be done in outbreak, but it can be done anywhere. For example, you are running an intervention and you want to understand what are the training needs. You can do a need assessment of your staff with respect to even M&E. So need assess, or if you are running an intervention and there are community whom you are providing service, the community may have some other need, and you can do a community need assessment. So need assessment is there which can help you design a project or an intervention later, whereas pilot is you have an intervention and you are trying to implement it. So I hope I answered.
Rajan sir, would you like to unmute and ask your question?
Good afternoon, sir. Sir,
Good afternoon.
as long as we are talking about quality of data, so is how desirable is replicability for a set of data, or is it just desirable?
Replicability of data.
Yes, sir. Say for a collection, and suppose if we have same set of data collected over 2-3 different observations, so do we insist on replicability that much, or not so much?
It depends on the type of. Are you saying that we collect data from the same person multiple times?
No, sir, on a single time, because not in a longitudinal model, but
Hmm.
say same set of observations by 2 or 3 different observers, sir.
Okay, so it depends on the interventions requirements, whether 3 persons should observe a particular person and then only record. So usually that's not necessary,
Right,
unless, because what happens is, if we keep checking for every single person 2 observations or 3 observations by 3 people, then it will create a lot of strain on the resources. So what we generally do is, at times, some sample of it is rechecked by another one, so
right, sir.
that there is, especially suppose it is a blood sample or something,
Yes, sir.
then part of the samples will be checked. Or even it has happened that even in, say, surveys, even in impact evaluation studies, let's say you have sent a team of people for asking questionnaires, interview schedules they are using, and they are collected data.
Hmm.
And what you can do as supervisor is, suppose there is 50 such persons in a village or in a urban ward,
Sir.
you create a system of supervision where you randomly pick up 2 people and will ask them 5 questions, not the whole interview schedule, and
Right, sir.
you match. So that itself will ensure accountability. And but yeah, and then what we are also doing is, wherever there is observation errors, for example, a particular x-ray to be given to 3 people, they may give different answers. So we
Right.
are in terms of measurement, we are moving towards a system where there is more standardization. So it depends on what you want to measure, but usually we do not go for a whole set to be redone by another one.
Fair enough, sir. Hmm.
Yeah.
Right. Thank you, sir. Thank you.
Thank you.
In case there are more questions, participants are requested to please post them on the WhatsApp group and we'll forward them to sir and then request him to answer them for us. Is that okay, sir?
Yes, that is
Okay,
fine.
thank you so much, sir. Thank you so much, sir, for your time and facilitating this session. Thank you to all the participants for patient listening. A kind reminder to all the participants to please prepare their final PPTs and submit them for review by at least by Wednesday, so that it is easier for me to review and reply to those PPTs. The next session, that is module 10 session, will be held on Sunday, 9th June. Please note, next session, module 10 session, will be held on Sunday, 9th June. I'll let you know the timing later. Thank you, everyone. We'll conclude the session now. Thank you, sir.
Thank you very much.
Thank you, sir. Thank you.
Thank you.